Hello and welcome. Chuck Bukata, Risk Management Monthly, coming to you November 2023. On the line is Kevin Klauer in Ocala, Florida. Kevin, how are you doing? You had just told me that you still have a little work to do today. You're the only CMO that I know that sees patients.
Well, glad to do it. Good to see you, Rick. And there's always a little work to be done, and I'm glad that we could do this recording today. So
Yeah, I'm glad
glad
you
to.
slipped it in. I do. And we have a special guest, somebody that you and I have known for a really, really long time. And in fact, Jen was on a Risk Management Monthly a number of years ago, and it's like, I really think I had a some kind of a brain lapse because it's been so long. But anyway, Jennifer Stankis is with us. Jennifer is a emergency physician and an attorney as well. She's broadcasting from Las Vegas. If
That's
that's
right.
if yeah. So Jen works at and she's worked at Brooke Army Medical Center for a long, 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 long time.
Madigan, actually.
That's what I
Madigan Army
said.
Medical.
That's what I
Yeah.
said. Madigan Army Medical Center up in Seattle. I got them totally wrong. Anyway, I'm sorry. Um, where she has been there a long time, teaching the residents and having a pretty good time. But what's most interesting about Jen is what she does in her other time when she's not there. Um, she's been a policeman. She's been a judge in the military. She does case reviews. Well, a lot of MD, JDs do case reviews that are kind of malpractice focused, but Jen does ones that are related to the criminal side of medicine, which is really interesting. And Jennifer, maybe you can tell us a little bit about that. But if you go onto her LinkedIn homepage, and if you have a half an hour that you would like to spend, I have never seen anybody who's done more in terms of as through her career than Jen, that is in terms of diversified. Um, Jen, there's a picture. I have a picture of you, Jen, on American Ninja Warrior. How many emergency physicians do you know that has been on American Ninja Warrior in your life?
Well,
Kevin,
I know there's
five or six?
one, at least one, but he was called Ninja Doc and he did a lot better than I did, but not too many. But I would expect of doctors who are on the show, I would expect the majority to be EM physicians for sure.
Oh yeah, I think so as well. You transitioned from your American Ninja Warrior thing to a number of TV kind of related things, and tell us a little bit about what you're up to because I think it's fascinating.
Well, so you know a little bit about my background. I started off at age 17 in the Naval Reserve as a medic and military police, and then went to college, worked my way through college, worked in law enforcement, ended up going to law school. And after I finished law school, I went into the Army as an active duty officer. And I worked as a hospital attorney doing medical malpractice defense. I had $600 million worth of claims right out of the chute, out of law school, and then worked part time as a military magistrate because of my law enforcement background, supporting the criminal investigative division. And so then I got out of the military. I did a little bit of time working with trial support with the U.S. Attorney's Office in Tacoma, Washington, and then matriculated to the University of Washington. The day I got my acceptance, I joined ASEP. I knew I'd be an emergency physician, having done ski patrol and mountain rescue and medic stuff. It's just in my blood. And so since that time, I've like you said, I've gotten into testifying. I always wanted to blend law and medicine. It was never my intent that I would do a lot of criminal work, but I did some cases, and word got around about me and my work, and now I'm like overwhelmed with cases. It's funny, but getting back to the extracurricular activities. A friend of mine, Bob Solomon, actually, if you remember Bob from
Hmm.
ASEP, he was a big name in ASEP for a long time. And he called me up one day and he said, Jen, I just saw this show called American Ninja Warrior. And there's this woman on there. Her name is Casey Catanzaro. And she's the first woman who ever completed the course. And he's like, I can't think of anyone but you, any other woman who could do that. You got to try out. So I did. And I got on the show. And it was so much fun. I really enjoyed it. I enjoyed the challenge and having something to work for. I was always in sports and that sort of thing. It's really, I'm very goal oriented, if you've noticed from my CV.
I think I got it.
And so then another opportunity came up. I like shooting sports and military style training and hardcore stuff. So another opportunity came up where I tried out for a show called Surviving Man. It's MANN. And Mr. Mann is a former SEAL Team 6 guy. He's still working, or at least until recently, working with the CIA, training people to infiltrate and exfiltrate hostile, situations. He's written 20 best-selling books. And so I have to admit, I was really scared. I was like, surviving this guy. I don't know about this. But I went and I had just the best time. I did really well. I won a dive trip to Belize. I'm a big cave diver and technical scuba diver. And so that was great. And then I was asked to be on a follow-up show and a follow-up show and a follow-up show. So at this point, from 2 years ago, I've now been on like 6 different shows, 2 shows across 3 seasons, actually three shows across 2 seasons. And then in that time, I've gotten back to my childhood dream of maybe writing a screenplay and producing some other TV shows. So I'm really fired up and just enjoying life.
You've enjoyed it the whole trip. It's been incredible. And Kevin, there's I feel so inadequate here between
maybe
two hyperachievers, but you are also in the category of hyperachievers as well.
Well, I tell you what, Rick, I think you're very kind, but maybe if we combine our personas on this particular monthly issue, we can match that of Jen Stankus. We'll try. I don't know if we get there, but I am feeling somewhat eclipsed also, and it's a good feeling. It's fine.
Okay, well, let's get started. You have a case, doesn't really necessarily relate to a screw up by emergency physicians, but it involves a diagnosis that I think it just scares me, this diagnosis, because it's so easy to miss this.
Now, absolutely. So if you take a look at this particular case, very interesting. So 36-year-old who, where this starts out, did have some cognitive impairment. So there was developmental delay. And so didn't really convey much of a reliable history. But in the past, also related to that, had an undisclosed and undefined quote unquote heart valve surgery. Presented to the emergency department several weeks of vague symptoms, vomiting, diarrhea, some shortness of breath, anything that is listed on the medical record was checked off. Chest x-ray revealed cardiomegaly and a possible infiltrate. And I'm not so sure retrospectively that they really looked at cardiomegaly as something that was important enough to further investigate. CBC, CMP, all that were normal. They said, well, let's start some antibiotics, probably pneumonia, because there's a possible infiltrate. Now, what I don't know, and we don't know, is this the infiltrate you wanted to see because it filled the expectation and fulfilled the expectation you had of finding a pneumonia, or was it real? Because pneumonia is a clinical diagnosis, not a radiographic diagnosis. So that's where we start to get pulled off the right track for the wrong reasons here a little bit. And of course, this is a bit of retrospective analysis. 6 days later, now we still have diarrhea and we're vomiting, but now we're sweating with it. That's really the only difference noted in the medical record. And so patient does follow up. Nurse practitioner repeated the chest x-ray, which had persistent cardiomegaly, but no infiltrate. Maybe they got better, but the cardiomegaly persisted. Antibiotics were stopped and a viral syndrome was diagnosed. So 6 days later, I'm not certain if they had a full course of antibiotics. It was not disclosed what the antibiotic choice was. 10 days later, he described, further vomiting and abdominal discomfort and a puffy abdomen. I'm not sure what that is, but I would not want to have one. And also reported decreased urination. Mother noted sweatiness and shortness of breath. But listen, creatinine was 1.6. And also, decided this was a viral illness. Well, if you are dehydrated enough or third spacing enough to the point where you're hypoperfusing your kidneys to where you've got an elevation in creatinine, technically, you might look at that as acute renal failure, although probably pre-renal. 12 days later, I'm seen by an NP again. The patient noted abdominal distension and vomiting. And I think the abdominal distension and the puffy abdomen might have just been a little bit of a red herring, but you'll see where it comes into play in just a moment or two. UA showed bacteria. Well, thank goodness. If we see a couple bacteria floating in the urine, no need to look any further. Cipro, and we'll order a CT. So results later that day, because they looked at the CT, and of course it showed part of the chest as well. Cardiomegaly, bilateral pleural effusions, but get this, ascites and anasarca. Well, anasarca would have been seen on examination, but the ascites was confirmed on the CT. And so this person had a lot going on there. Patient's physician advising them to go to the ED, and they diuresed him. I'm sure they did more than that, but that was reported as the primary step to treat him. Went to his bed at 5 a.m. An echo was ordered. Tech called the cardiologist to say, oh my gosh, the left ventricular ejection fraction was severely reduced. Didn't report the percentage, but pretty darn low. 2 days later, now we're at day 15 of this saga, another cardiologist, I don't know if the first cardiologist got fatigued or went on vacation, but a second cardiologist came in and the formal echo report was still pending. They could read it. They started Coreg. Interesting choice on somebody with decompensated heart failure, but nonetheless, it was started. 20 minutes later, the patient arrested, and that's the end of the story. This was a dilated cardiomyopathy, basically from myocarditis, with some very vague symptoms and some historical factors that really lead you probably off the right path for the wrong reasons. So I think case in point, if you don't have a firm understanding of what's happening, don't force a square peg into a round hole, and look at the very firm things that you do have. The history was unclear here. Cardiomegaly that's unexplained in a 36-year-old needs to be followed up, and probably needs to be followed up more extensively than the way it was in this particular case. So your thoughts, Rick, Jen?
Jen?
Yeah, I mean, this just goes back to all the basic principles of why we make mistakes in medicine. I mean, the first one is, you're trying to fit a square peg in a round hole. Like, things aren't really adding up. Like, oh, good, infiltrate. I'll hang my hat on that. Okay. I think more could have been done at that first. I agree with you that you've got a new cardiomegaly in a young, otherwise healthy patient. That's not normal. That doesn't happen because you have a pneumonia. So how do you explain that? If you can't explain things, step back, get a lifeline, ask someone else. But then as the patient keeps bouncing back and bouncing back, like, they're trying to manipulate that original diagnosis. Oh, well, it's not a pneumonia. We'll just call it a viral illness, rather than stepping back and saying, well, there could be something bigger going on here, which is our obligation as emergency physicians, is to find the big bad things, even if they're subtle like this at first.
You know what? No vital signs were provided, and I think that it's always difficult when we get these cases because we're really not getting all the details, and we're getting it selected bits and pieces, and it is easy to be a Monday morning quarterback. However, no vital signs were provided. I'm sure there were vital signs, and one of these things that would really be tipping people off is arresting tachycardia. It's like the heart's trying to compensate, and it can't pump any harder, so it pumps faster. And I think that tip-off is often kind of neglected, and yet it's there in the chart, and and yet we're going for the common diagnosis, the diagnosis that we see all the time. Okay, it's pneumonia. Okay, it's a urinary tract infection, when in fact it's a much more uncommon diagnosis that we have to put into our differential that we often fail to do. This case was reported in MedBal Reviewer. That's Eric Funk's publication, who reports these cases across all specialties, but he's an emergency physician and focuses largely on ER-related cases. And although there's no claim of problems by the ER doc here, it just was another case of multiple visits doing Kevin's favorite saying, square peg, round hole.
Yep.
And I think that's how we really get in trouble because we don't expand our differential and we go for the common diagnoses that are very misleading in this case. And wrongful death action was claimed here. Yeah, I don't agree that. Yeah, beta blockers probably in acute heart failure probably really don't work that well.
Probably not. And I would say if you like square peg in a round hole, wait for this one, Rick and Jen. Let's look at the data and the information we have and sort out the signal from the noise. And I think that's frequently the job of the emergency physician or whoever's caring for a patient who's acutely ill. So when I read this summary first about this case, vomiting and diarrhea are nonspecific.
Right.
Shortness of breath jumped off the page at me. I know how we get pulled off the right track for the wrong reasons, as Jen said, with a infiltrate, not even a committed infiltrate, a possible infiltrate, one that I hope was there, one that might blossom if I hydrate, all those wonderful things that we talk about.
Mm-hmm.
But we've got cardiomegaly and shortness of breath. Those are the signal. The rest of everything else is noise. Vomiting and diarrhea are symptoms that are non-specific. You come back and did they give you anything more? Well, I'm going to sweat with my vomiting and diarrhea. No, but what is the signal there? I'm not better. I'm not better. And 10 days later, now what are two new findings? A puffy abdomen. What do you mean by that? Well, I'm distended. Well, would that go along with cardiomegaly and shortness of breath? If you add cardiomegaly with shortness of breath to abdominal pain, what do you get? Fluid overload. If you look at the signal and discount the noise, I think you're in much better shape. And that's the fun part of the puzzle of the details of the facts we get from history and physical, supplemented by the diagnostic evaluation. You can't explain away a creatinine of 1.6 that was formerly normal in the context of shortness of breath, cardiomegaly, and everything else that's happening here. It's a pretty concerning thing. So you should know that this is progression going the wrong way. Abdominal distension, along with all of this, really speaks to the concept of third spacing of fluids, which certainly could be a cause, certainly of renal hypoperfusion and an elevation of creatinine. And maybe a little bit of a stretch. Retrospectively, I know it's easy for me to say, but if we're looking for the signal, we're more likely to find it and not get buried in the noise.
Excellent discussion of the signal to noise ratio, and we'll combine that with the square peg in the round hole, and we've got this whole thing covered. On the first visit, a chest X-ray was done, and that suggests to me that this shortness of breath thing was of enough significance to warrant a chest X-ray being performed. And then when you see cardiomegaly in a 36-year-old. And speaking of the red herring, well, he had some surgery in the distant past regarding some heart valve issues, but that doesn't entitle you to have cardiomegaly in a 36-year-old. So I guess there's just a whole bunch of kind of things that, in retrospect, should have tipped us off in this case a lot sooner. Although I don't honestly know. It's such a discouraging diagnosis because, I don't know that there's all that much you can do with it, to tell you the truth. No. I mean, clearly you treat failure, but I mean, the primary etiology of this thing is, you can't make it go away. I remember seeing not too long ago a histologic slide of myocardium in the setting of myocarditis. And there is all of this myocardial muscle, and all of these white cells are all over the place infiltrating this, and they had it compared to a normal heart muscle and a cardiomyopathy, viral cardiomyopathy, and it was like, wow, big difference. So I just say, please be careful, and watch out for these vital signs, which are unfortunately not suggested here. Any last thoughts, Jen?
Yeah, the only thing I would say is that, just like I teach the residents, and what I have to tell myself all the time is keep the differential wide. Mm-hmm. And if you're looking at shortness of breath, they're not just pulmonary causes, they're cardiac causes. So, run through those. And if you do start to run through those, you're like, okay, Well, how do I square, no pun intended, Kevin, how do I square, how do I square this cardiomegaly in this setting? Like that should, like if you make it a practice to go through the big things, the big broad categories of an important characteristic of the patient's complaint, I think that the risk of missing something like this is lower. I agree, this is a tough one, but it's lower.
And if I can add to that, I know we were ready to move on, Rick, but I tell you, it's interesting when you look at defense strategies for clinicians and the diagnostic choices they make. Now, I don't know all the details, and I'm certain that there was reasonable rationale for ordering the chest X-ray. But oftentimes, I've been in a situation where I can formulate a better defense strategy if you didn't order the test, meaning,
Yes.
listen, there was absolutely no indication for anything serious going on, so I didn't order the test. Even retrospectively, if they say it was something that could have been discovered on a chest X-ray, well, when I saw them, they had vomiting and diarrhea. I wasn't going to get a chest X-ray for that. They didn't look sick. They had nothing pulmonary or cardiac going on. If you're going to order a test and there's an abnormality on it, you own it. And you've got to respond to it in your medical record, either explain it and not do anything about it because you've agreed that you've reconciled it and there doesn't require further follow-up, or you've got to do something to say, well, now I've got the cardiomegaly I wasn't expecting. Maybe I should get an ECG. Maybe I should schedule them for an outpatient echo. Maybe I should refer them. You have to take an action or you have to explain why you didn't. But it might be the better part of valor at the beginning of a low acuity visit to say, I don't need tests because they're not sick. So I'm not just going to reflexively order any. And I think that's a wonderful strategy to show why you felt the patient wasn't really at risk at all.
Right. That's why we were inferring that this shortness of breath was warranting chest X-ray. And then they have a small possible infiltrate. Well, how does that explain shortness of breath? The people who are 36 get shortness of breath from a small infiltrate that is plus could be there or maybe not be there. They don't really go together. But
And I'm going to jump in on this topic that I do think, I agree with you. We're going to make the assumption that shortness of breath was important enough to get a chest radiograph. But the number of chest radiographs that are ordered without clear indication or ordered with a soft indication are so numerous that I think this could have easily fallen into that category. Now we've got what they believe to be an incidental finding, which was insignificant at the time, which really was the most important finding of the day, was the incidental finding of cardiomegaly on the chest X-ray, because I don't know if they were really looking for specific pathology.
Well, Jen, you work
Well,
with the residents.
I would just add one more thing to that, and that is that it is possible, and again, I don't know, it's Monday morning quarterbacking, but someone comes in with shortness of breath, they're not feeling well, they have these vague symptoms, they're looking for pneumonia. I mean, that's what they're looking for. And they see something else and they just lock in on the possible infiltrate and they ignore the rest when the rest is what's important.
Great point.
Jen, are you when you work with the residents, is there this tendency to be aggressive in ordering or not? Because my sense is that when I look at some of these cases, there is just a huge amount of ordering that goes on, particularly when it's done by triage. And here's our protocol, and we do this on everybody who has this complaint, without a physician kind of sorting out, do I really need this or that? And I think after a while, a workup becomes very standard in terms of I do this, we do that, and everybody does it, kind of thing, and nobody cares what it costs because we don't know what it costs. There's what the charges are, and I think one of the things that residents need to learn is to kind of be thoughtful about what they're spending on the part of the patient.
I agree, and so my big lesson is always I have them think about every single thing that they're ordering. How will this change my management? Does it matter? If you order this and it's abnormal, what does that mean? What are you going to do with that? When they come to me and say, well, I want to get a CTA of this or that of like the head and neck. Okay, why? What are you looking for specifically? What are you looking for? And sometimes I'm surprised by the answer. Well, I'm looking for a mass. Well, you won't see it that way. If you're looking for a dissection or something like that, sure, great. Tell me why you need to do that, and we'll go that way. So I just try to get people to think. I don't try to constrain their practice style. Everyone's different. Everyone has a different level of risk aversion. But I at
Yes.
least want them to be able to say, this is why I'm doing it. This is why it matters. And a lot of times they're like, yeah, you're right. I probably don't need that.
Yeah. And Jen, I will add something I've shared with some others too, and maybe this is part of your discussion with your residents and what are you going to do with it? I mean, if you're not going to change your management with that particular diagnostic, you already have the answer, or you're not going to change your approach, then it's not an essential diagnostic. It's not worth the time, the energy, or the resources to do that test.
Exactly.
And as you mentioned, Kevin, this is a great example of where taking the chest X-ray will more likely harm your case than help it.
It did in this one, that's for sure. Although, since it was real pathology, even if it was inadvertently stumbled upon, because they weren't looking for that, if they would have acted on it, it would have been an amazing finding. The best medical Easter egg ever had they found it and acted on it, but they didn't.
And I don't want to. It's not laziness. We're all incredibly busy. In a busy ED, it's more like a relief. Oh, thank God. Okay, there's that diagnosis. Bam, moving on. Instead of like taking that 30 seconds before you discharge that patient and look at everything, look at all the abnormals, put it together. Does this fit? Is there anything big I'm missing that I haven't addressed? Oh, the cardiomegaly. Damn, maybe I should have him follow up or whatever.
And then, when you throw out that net and said, okay, let's order a UA in a 36-year-old. What's the likelihood of a 36-year-old male having a urinary tract infection? And do we know whether there's a fever or any other urinary symptoms? Probably zero urinary symptoms in this case. But here's an opportunity, exactly as you said, Kevin. There's a few white cells, so it's probably a urinary infection. But young males don't get urine infections, kind of, so it's like you've kind of tried to focus on the easy diagnosis when really with a little thought, it's not an easy diagnosis. Diagnosing a UTI in a male is not something that happens every day.
Absolutely.
Moving on.
Yes, sir.
This next article, I think, is just absolutely fascinating. Rising high acuity emergency care services independently billed by advanced practice providers between 2013 2019. This is Academic Emergency Medicine by Dr. Gettle and Associates, March 4th, 2023. I don't want to be a broken record, but on this thing I've said about these cases in the past. So one of my relatives had surgery, intra-abdominal surgery, and 10 days later was short of breath, and ultimately he went to the ER for an evaluation. Pardon me. And obviously at the top of the list is PE, and they do a great evaluation for PE. They do a CT coronary angiogram because he's not a low-risk patient, and it doesn't in that case matter what the D-dimer is. If anything, it may mislead you. But in any case, it was normal, and he went home, and there was no consequences. And what it was, God knows, but it wasn't a PE. And he was never seen by a doctor. His wife,
yeah,
his wife goes to an emergency department with diffuse abdominal pain, with no fever, GI symptoms, urinary symptoms, just abdominal pain that is lasting days on end, and it's getting worse and worse. She goes to the emergency department. CT's normal. Everything else is normal. They send her home. 2 or 3 days later, she goes to another emergency department because her pain is unrelenting, and the second CT is read as showing enlarged lymph nodes. Now, these lymph nodes didn't increase from day 1 to day 3, but anyways, maybe it was more apparent on the second. And so ultimately the diagnosis for her diffuse abdominal pain is these lymph nodes stretching tissue, causing her to have pain, and she has a non-Hodgkin lymphoma diagnosed. Again, not seen by a physician. And it's like a 65-year-old with abdominal pain kind of thing, without nausea, vomiting, diarrhea kind of thing. What the heck? And I just think that honestly that shouldn't occur. So this article is right on target. This article looks at level 5 and critical care cases that were billed to Medicare patients with no physician NPI number on the bill, just strictly a PA number. And the bottom line was that there's a lot of statistics in this paper, and I encourage you really to get it. Bottom line is that in rural areas, as you might expect, a higher number of these cases existed. 1 in 6 high acuity encounters in rural geographies were reported by PAs or NPs with no doctor seeing the case. And maybe you can say, well, in rural areas, maybe there's not as many opportunities for a doctor to see them, and there's these a few places where just the PAs and NPs are working. There's no doctor, but in any case, I think that's the substantial minority. And then there in the urban areas where there's lots of doctors around, it was 1 in 11 cases are billed to Medicare, level 5 or critical care by a advanced practice provider. And I'm not sure whether these numbers are good or bad or what you want to interpret of them. I have an opinion, but I'd be interested in what you folks have to say.
Well, I'm glad that Kevin is in a position like he is as a physician. It's my experience that most administrators, their job is to control costs. It just is. And it's a cheaper form of labor, which is a little bit concerning. And it's even a cheaper form of labor for big staffing groups too. If
Right.
they're billing the same amount and paying that person less, it's more for the group. I just, if I could have one wish, it would be that healthcare was not for profit, and that we didn't make decisions based on money, but rather on best practices and care. But that's just a dream, I guess.
No,
Kevin?
it's a good dream. And I would say, and this can certainly be a philosophical discussion that goes way beyond where we are today. But I think regardless of the financial structure of an organization, not for profit or for profit, if your mission is solid and you are executing on that mission and you're living up to it every day, and if that mission serves others, there's nothing wrong with making profit if you do good things with those dollars.
Yeah,
Serving the people doing the work, serving the patients, providing better service, that's a good thing. And please make no mistake, just because you may be structured as a not-for-profit, you can still make profit. You are just required to return that profit back to service of the mission, which is a very, very broad definition, and it's easy to do. It is a bit of a different focus, but there are many, many places that are not for profit that have plenty of profit. But I agree with you that we have to make sure that we focus on doing the right thing for patients. And yes, there are organizations and there are administrators that do have to make sure that the care that is delivered, the service that is provided, is cost effective and it is efficient. But at the very, very root of that must be service to the patients and service to your staff, service to those who are providing the care. One cannot be done without the other. You can't make things cost effective at the expense of your staff, at the expense of your patients, or vice versa. It cannot happen that way. And people who are truly committed to a good healthcare mission will make sure that happens, regardless of their financial structure. That's my perspective on it. Now, on this topic, I think this whole discussion comes down to the concept of skill set substitution. I think physician-led, team-based care is a very, very good model. And are there some economic benefits with skill set substitution? Yes. Do some go too far to the point where some patients don't benefit from the physician level of care that might be good for them? That happens sometimes. So we have to strike that balance. Where there are lower acuity items or visits that can be seen, there are items or procedures that can be the people can be trained to do. those things can be delegated. But Rick has said this for years, and I love it. He looks at the emergency physician and other physicians as a free-floating brain, a free-floating intellect, making the high-level cognitive decisions in care. And that's our best value, not necessarily doing all the procedures and seeing every patient. So striking the balance is important. So Rick, I'll turn it back to you because that has been your mantra for years, and I've loved the way you've worded it, and you are so right. The free-floating intellect in the emergency department.
Well, that was focused on, taking charting away from physicians, taking all of this non direct care work away from physicians. I mean, you go to an ER and all you see is all of these people in white, nurses and doctors at computers, and it's like, oh God, where have we gone? And so the idea, one of the problems with this paper is that people will say we are kind of trying to talk negatively about PAs and NPs, and that I just want to say that is totally false. We have a course called EM Boot Camp, which has had about 20,000 PAs and NPs attend over the last 10 years. And it's kind of like we are fans. And I think frankly, if you have an emergency department with any kind of volume worth talking about, and you don't have PAs and NPs working in that environment, you're really foolish. So I think it's ridiculous, but I think that we need to work together. And I do believe that this idea of these are my patients and these are your patients is fundamentally risky, and that patients have certain expectations when they go to the emergency department, and I want us all to be working collaboratively on these cases. And I think if we do that, we'll get the right people for the job, and we'll have everybody getting the best level of care we can. I know that sounds like a little apple pie and motherhood, but I think that's really where we ought to shoot. And let me just quote to you the conclusion of the authors of this paper. Given differences in training and reimbursement between clinician types, these estimates suggest further work is needed evaluating emergency care staffing decision making. So they're relatively aggressive about this, but don't really hit the nail on the head about what I think they're trying to say. I personally don't think level 5s should be seen exclusively by PAs or NPs. I'm going to go out on a limb. I know that's going to be viewed as your old fashioned kind of thing, but I think it's really the way I feel. And I don't want to have you two commit, because you're in a much more vulnerable position than I am.
I agree with both of you. I think we are known as emergency physicians as great team leaders. That's what we are. We cannot work without a team. And the way the best departments have run that I've been with are ones that have really good high functioning mid-levels, and they just save my tail all the time. So I mean, they love doing procedures. When I was early in my career, I lived for procedures. Now I see a procedure and I see a huge time sink that I don't really have time for. I need I need to be somewhere else. I need to be doing something else. And these aggressive young, providers really want to get in there. And I agree. I don't think that the super high acuity patient should be seen primarily by a PA or an advanced practitioner provider, but I do think that it's good to bring them in. Like for me,
absolutely,
it's nice to have a second set of hands, and it's good for them. They're learning more, and because they have to see the really high acuity things to recognize them. So it's a win-win bringing them in. I just think that you have to be careful to make sure that the appropriate supervision is there.
No,
yeah,
I
I want
agree.
a PA and NP to see every patient in the department. I don't want them to say, well, this is my patient and this is your patient. I would want them to see all the CHF patients and all the myocarditis patients and all of these cases should be seen collaboratively. I just don't want them seeing the I stepped on a nail case.
Well, and I tell you, there are many advanced practice providers, physician assistants, and advanced practice registered nurses that I've worked with through the years and that I've spoken with who've worked with others that don't feel comfortable being put in a position that they're not prepared for. So,
Yes.
so a couple of things come to mind with this conversation as well, and this collaborative approach. I think if there's a good working relationship and there are structured policies that guide what the responsibilities are, I think the advanced practice providers can get involved in every case, just as you suggested, Rick. And I would say, too, I think of it as opposed to um, the coding nomenclature, I go more to ESI. Do I want, is it ideal? Let me word it that way. It's not what I want. Is it ideal for an ESI level 1 to be seen solely and primarily by an advanced practice provider? Well, there's probably some value that the physician has to provide in the highest acuity case. So let's get the physician involved. Am I opposed to an advanced practice provider starting that case when the physician's not available? Absolutely, get in there. But if you have the right supervisory guideline, and I will tell you, having drafted them in the past, you can give this guidance. So go ahead and start in anything once you've gotten to a certain level of proficiency. If you're a new grad, that may take 6 months. There is an extensive onboarding process. Once you've met milestones, you're allowed to do different things. So when you get to that point, you can see those cases first. You're required then to immediately then present an ESI 1 to your attending, and then you turn the care over. They may allow you to participate in it. You'll work together. But it shouldn't be, oh, I've been seeing this one. I intubated them and I've been seeing them. They've been in the ED for 4 hours before the physician is aware. So you just make sure you set up the expectations and appropriate guidelines and policies that works for everyone. As first, the patient, and second of all, for the advanced practice provider and the physician that are involved. And it really provides care more efficiently. It lets everyone see high acuity cases, and it puts, I think, as Jen said, more eyes on the case on the more complicated ones. Just because you're trained at a different level doesn't mean you don't see things differently than the other person. And as you gain more experience, you may see things that are really valuable to each other. So I think if you look at it that way, absolutely, I think we can work together, and it makes an awful lot of sense. But just having those patients, Rick, you stated it, these are yours, these are mine. Just because we both wear a lab coat, we're next to each other, but we're not working together in an ED, is probably not the best scenario.
Any final comments, and or we'll move on? All right, let's go. Democrats, atheists, and females need not apply.
I am so glad you read the title because I didn't want to. It is
a great title.
It is a great title. It's not ours. It came from the article itself. And I'll tell you what, I'm making that disclaimer. I'm stating that disclaimer because it could be a bit offensive to some. I know that sometimes the lay press tries to catch people's attention, and they certainly did with this one. But let's tell you about it. An emergency physician has sued the county hospital where she had worked for 8 years. And some of the part of the complaint was that she was harassed, belittled, reprimanded, humiliated, excluded, terminated, and retaliated against because she was a woman and she was an atheist. She was also suing the CEO, who started at the hospital 5 years after she did, and the ED medical director, and the hospital's medical director, and some of the members of the board of trustees. So you've got to name all potential defendants if you believe that they're contributing to the issue that you're pursuing. It was claimed that the defendants, quote, have a history of taking discriminatory acts against female employees and those who do not share their religious faith and political views, end of quote. Fascinating when you read the details of this case as well.
Nutty.
It is, because the political view part, they actually had a PowerPoint presentation, a few of those named that I just mentioned a moment ago, that suggested or actually told medical staff members why they should vote for a certain candidate, and it happened to be Donald Trump. So with people who didn't like Donald Trump, that didn't go very well. And certainly your employer shouldn't be telling you who you should vote for, that's for sure. CEO and the CMO, according to the lawsuit, they pushed their religious ideas and beliefs onto the employees. The two basically really went way beyond just suggestion of what their religious beliefs were. They told the entire executive team that they were chosen by the hand of God to lead the hospital. And the CMO allegedly insisted on praying with patients, two of whom complained that they didn't want to pray at that time. So a little bit of an imposition of belief and thought in the wrong environment,
A
for
little
sure.
bit.
A little tiny bit, an overstep for sure, a big overstep that resulted in a lawsuit. So make just to bring this to conclusion, to make a long story short, 3 of the 5 emergency physicians at the hospital were fired. All were female, including the plaintiff, and this was back, roughly about 2 years ago. This physician, the primary one, had never had any disciplinary action prior to the suspension. So basically there was no stepwise discipline. So this looked very retaliatory, and it may well have been. We don't have the final outcome at this point. 3 of the board of trustees resigned. A male surgeon was hired to work in the ED, and he had no emergency department experience. And so the case is currently with the U.S. District Court, and I think it's still there in the state of Iowa. It may have progressed, but I'm not sure of the outcome. But you've really got to decide, where the boundaries are. Certainly, politics do not play any place at work, especially your own personal beliefs. Where we can advocate with political positions and advocacy to help our patients, to help professions, of course, that makes sense. But personal perspectives are not welcome in the workplace. And certainly gender discrimination, absolutely not. It goes without saying, but we have to emphasize it here. But the focus of the article was really about the religious beliefs. And even if you look at Title VII of the Civil Rights Act of 1964, way back then, no, your employer can't discriminate against applicants or employees or anyone in your environment because of religion, on the basis of religion. That is exactly what appeared to happen here. And even so, I'm going to go one step further. I don't know the name of the system or hospital. I suspect it probably had a religious basis or religious foundation. Those hospitals are not exempted from Title VII. You can have a focus, but you cannot impose it or discriminate against people based on that focus or based on that foundation, based on your history. So absolutely, there's a concern with this case.
This case was more like fun than
Yep.
a lot of take-home messages here. These guys crossed the line big time.
Yeah, PowerPoints. Wow. I mean, that's a way to document,
Here's the
your
evidence.
culpability. Yeah, here's the evidence. Let's document it. So,
I would just have like one thing to say, and that is that, life is so much more fun when you can be like me and have friends in high, low, and medium places.
Yes.
Like, in all seriousness, like, we have gone so crazy. I mean, this is such an extreme case, but you see this everywhere. You see it in all work environments to some extent anymore. It seems like, one political view versus another. I like this group or that group. And it would be not, as an emergency physician, it's one of our tenets, right? We treat all comers. We take care of everyone equally. We think of everyone as a human being worthy of our attention, and even when they test us. So I don't know. I think that I don't know what to say about this case. That's all I have to say. It speaks for
I'd like to be an investor.
It does speak for itself. Yes.
I'd like to be an investor in this case. Isn't there this thing where you invest in legal cases and help fund them, and then you get a piece of the action?
I wouldn't want any piece. I wouldn't want any piece of this, Rick. I would run from this.
This doctor's going to win this thing.
Oh yeah. I was running from the title, let alone the case. I mean, I just would not want to be a part of this at all.
Yes.
So,
well, I think you got to call
situation.
a spade a spade. There are, I'm associated with a hospital that's founded by a religious society, and they say they have one of the hospital chaplains gives a thing at the beginning of the executive committee meetings, and they're non-denominational kind of thing, but there's people in the audience who don't believe in God anyway, and so it's kind of weird. But nobody ever raises their hand and say, I don't want to be here. I don't want to. They don't push back. They just kind of, okay, this is the way they do it.
Absolutely. So if anyone wants to read more about it, This was in Becker's Hospital Review, April 26, 2023. The author is Kelly Gooch. Physician sues Iowa hospital executives for alleged religious discrimination.
Okay, that there's not a lot of take homes there. I don't think it, because I don't think anybody is that nutty to do what these people did. Let's go to the next
Someone
one.
was.
Go ahead.
I beg to differ.
Oh yeah,
Yeah, they were
Well,
all in the same place though, Jen.
Yeah.
Those are all the people who would do this. They all worked at the same place.
what do we get up next? Oh yeah, okay. I I saw two articles recently, both that on the same topic. The idea that system errors are not adequately acknowledged as a cause of getting ER doctors in trouble. And the first one was by Tom Berlinger, an ER doc who wrote in Emergency Medicine News this past June. His article is titled "EPs Often Blamed for System Errors." And the other article, which is even more specific, is "Misplaced Attribution for Malpractice Claims Further Phrase the Safety Net Provided by Emergency Departments." This was in Emergency Medicine Journal in March. And both of them basically kind of make the point that system errors are often the cause of malpractice claims in the emergency department. And I think it's easy to point to system errors, but while we've been doing this for these umpteen years, I've never heard of a case where the ER was viewed as because there was 20 patients in the waiting room that allowed you to make this mistake, or because this patient was being held for admission for 6 hours that allowed you to make this mistake in that patient who was being held and who nobody was watching carefully because they were already being admitted. And so that this idea that system errors are a big source of mitigation, I honestly don't actually see that happening in cases. Every time they look at what's the cause of these cases, 70% are failure to diagnose, failure to treat. It's not that, the waiting room was full. It was not that you were holding patients, even though I sincerely believe that, creating a chaotic environment in the department has got to basically cause more errors to occur. And the errors are errors of, I made the wrong diagnosis. I forgot this one of the elements in this treatment because I was just so overwhelmed. And then they say, well, was there any backup? Were all the nurses in place? All of these system related issues, they never come up in cases. It's just, you made a wrong diagnosis.
A jury doesn't care. A jury sits there and thinks, well, what if I'm in the ER?
Exactly.
Ignore me?
Exactly. That's exactly.
Well, it is a double-edged sword for sure. So one of the reasons it doesn't, in my opinion, and you can dismiss this if you don't agree with it or it doesn't resonate with you, and so can the listeners. But first of all, you have to point the finger at someone to make that allegation. So if there is most allegations fall into a larger bucket, right? Like you already said it, it's misdiagnosis, delay of treatment, you didn't consult, delay in definitive treatment, whatever it is, a small handful, but a variety of primary allegations. If you want to say, but I didn't do those things because this, you're either going to point the finger at your employer, your group is going to point the finger at who holds their contract. It's just, I'm not saying that's right or wrong. I'm just saying that is a dynamic that does exist. And so when you start pointing fingers, all you are saying with finger pointing in a case is that you both recognize that negligence occurred. You're just deciding how much the damages should be, and you're also going to decide what the apportionment will be. Actually, the court will do
right. You want to medicate your case.
So that's why you probably don't go there in a lot of cases. But I will say I've heard it come up in the fact pattern sometimes. So when you have one of those larger buckets of allegations, okay, delay in definitive management. Well, you know what? We didn't have a good transition of care for this reason. Did you have policy? Why didn't you have a transition of care? Well, we didn't have the resources we needed because we were way beyond capacity. And you have to be careful how it's delivered. It can be helpful, but that it can implicate then there was resource allocation or resource management problems. So if you can say, well, listen, it was really chaotic then, and it was a day that we couldn't have planned for, and that added to it, that could be a risk mitigator, but it's going to require an artful defense counsel to get that done without undermining your case. I think, here's my final initial word on this. When we start seeing a bunch of cases from the pandemic, that is going to be a primary defense strategy. Are you serious? How could we possibly have provided the standard of care under the circumstances? We ran out of equipment. We ran out of staff. We didn't even understand the disease. I think that's going to become more evident to us.
It will be. My intuition is that there are not going to be very many cases from the pandemic. I think that there was all of these legal. The bar got raised in terms of what it would take to sue. I agree with everything you said that would mitigate. We don't have pandemics that
Right.
often.
Well, and I'll just throw this in real quick. I would invite a case so that we can establish that as a precedent. So when we do have it and we say, listen, okay, we are going to give you a pass because it was unfair to you. Well, we've been dealing with surge issues which create risk for a really long time. And then we can translate that to normal surge. Go ahead, Jen. Thanks for being patient.
No, I was just going to say that, boy, the pandemic was such a weird time to practice. In the beginning, we were all heroes. Everyone was very grateful. Towards the end, it was the opposite. So if those do come, I think it'll be, it just goes back to patient satisfaction, patient trust, the interactions that really kind of drive lawsuits more than anything else.
Guys, the next section is actually about can your insurance company drop you? And there's a couple of these. Let's do the next two. Kevin, are you up here?
I am. I'm ready to go. Jen, you ready?
I'm ready.
Rick, are you ready?
I'm ready.
Let's do this. So could a malpractice insurer drop you when you need it most? So this was in Medscape, August 21st of this year. So here is the initial quote. All professional liability insurance policies contain exclusions, and it is essential that you know what they are. Well, of course, that sounds obvious, but it's true. I think we look at professional liability coverage as an absolute. It's not. Just like there are certain exclusions from your automotive policy and your home policy. So I live in Florida now. What's really interesting, we had tropical storm. After I got down here, we had a tree that was uprooted. And we had some wind damage. Well, I called my insurance company to see if they covered any of it. Well, if it's only wind damage, then it can be covered, but not wind damage from a hurricane. I was like, well, where do you think wind comes from? It was just, it was amazing. So there were exclusions, and it's just fascinating that you have to know your policy, and also in Florida, not to take too much of a diversion, but if it is let's say a total loss or a big loss from a hurricane or something, there's a different deductible. So they know, you're gonna get covered, but you're gonna pay a large sum to get your house rebuilt. So the same can happen here. So you're trusting others to procure appropriate professional liability coverage for you. That's good. I hope that you trusted people, but you verified. What did I get? And what are the exclusions? So there's certain things that aren't covered. And I think earlier in our careers, we think, thank goodness, no matter what I do at work, I have coverage. No, if it's not within the confines of the bounds of the job you were hired for, you're not covered. That's the basic premise. Understand that. If you're reckless, if you do something intentionally harmful to someone, criminal acts, you're not covered. You are on your own for all of it. Defense and any indemnity that would have to be paid out, or any criminal charges that are filed in criminal representation. If you did something that was not within the specified duties, you are way outside the bounds, or even a little bit outside the bounds, you are on your own. If the organization you're with is self-insured, they have the opportunity to extend coverage. They may choose to, but they're not obligated to. So if they have a risk retention group or a captive, and they will establish what the bounds of coverage are, they could make an exception. But if they buy commercial insurance, You need a copy of your declarations page so you can see exactly what they are and practice safely and try not to do things that put your license and your career and, of course, your liability coverage at risk.
Yeah,
Oh,
I agree. Some of these are a little bit surprising to me. And just from a lawyer perspective, and just looking at language, how these could be interpreted, it's not necessarily how the average emergency physician would interpret it. So, as an example, practicing under the influence of alcohol or drugs. What does that mean? Is it illicit drugs? Is it a drug that you take that's a prescription drug that maybe could have some cognitive changes associated with it, like an antidepressant or who knows what? Like everything's going to come under a microscope when big money's on the line. And just understanding that some of these are a little surprising.
Absolutely. But
well, that
just be aware of what they are.
that lays the groundwork for the next case. This is a neurologist who the medical board in his state got a little bent out of shape because they thought he overprescribed opiates and as a result was responsible for the death of 17 patients. Well, obviously this made the evening news, and one of the people watching the news was the insurance agent for the this doctor, who the insurance agent then called the insurance company and said, "Listen, do you know about these 17 cases of our client that may be coming down the pipeline?" Um, because the medical board suspended this person's license, the insurance company claimed that that allowed them to stop insuring this person, and that in fact, because these 17 cases were not uh, talked about in advance. None of them had sued at the time, but they basically say you're required to report cases that you think um, are likely to potentially get into trouble. And I think there's a gray zone there. But all of our insurance agents want us to report. Last night we really had a really bad case, and I'm really concerned that we may be getting into trouble in this case. That you call them about that, even though there's been no action taken, because their insurance company might say, "Listen, we are concerned about this case, and we would not like you to discuss it with others." All of the things that they would say to you when you are, in fact, named in a case, because they don't want you talking about every Tom, Dick, and Harry about what happened last night, when it's a concerning kind of thing. Well, the long and short of this case, which has got a little bit complicated, is two of the 17 patients ultimately sued the doctor, and the insurance company said, "No, I'm sorry, we're not going to cover it." The state was brought into the case, and it was determined that the insurance company was doing just about everything it could to avoid dealing with these cases, and it turns out that as a result, the neurologist sued the insurance company for failure to um, take on these claims. When it turned out there was basically just two of them, not the 17 that they were concerned about. The physician, after 2 hours deliberation, the jury awarded the physician $52 million, which is probably more than they would have gotten for the two people who died as a result of the opiates. Because you can there's really a touchy line between overprescribing and patients who have chronic pain and those kinds of things. And so I think there's a tendency for these doctors to kind of be in the gray zone in terms of their perceived culpability when a person ultimately overdoses. So that basically suggests that you can choose to sue your insurance company if they tend to not want to cover you, because they're trying to get out of as much of these payments as possible. Certainly, if you're crossing the line and you're doing things against state regulations, then you can be called on it, as this case shows.
Yeah.
Hey, Kevin, I have a question for you.
Sure.
There is a trend in different types of insurance, but is there any trend where if someone is found guilty of malpractice, that the insurance company can then have like a clawback clause, so to speak, that, well, you were found guilty, so we want that money back. We want all the insurance money to defend you back.
Not that I'm aware of, because it's really defense of your claim is part of your coverage. And so now if I think if they believe that you did not comply with the rules that they have within the policy, kind of what we were talking about before, they can certainly disqualify coverage. But they can't say, listen, if you were found negligent, and so that's kind of the way I would frame it, as opposed to, criminal guilt. Hey, if you were found negligent, well, we know we might be. That's part of what we're doing. This is the tort of negligence. So you can't then say, because negligence was actually identified, or a settlement or a judgment was awarded or agreed upon, that now we're going to try and get that back. This is what the nature of the coverage is. So I haven't seen it. I suppose it's a unique strategy people could use, but I have seen, as Rick commented about as well, if you're supposed to disclose cases and you never do, you can't get everyone to them. But if they show a track record that you're not disclosing anything, and then a case which is supposed to be reported to your professional liability carrier, especially when you are notified of it, there's a reporting requirement. So you may not know every bad case, but you get a letter of intent, a notice of intent to sue, or you get a subpoena, you get a legal document on a case, and you don't notify your insurer, and that lack of notification impairs the defense, oh, you absolutely may have your coverage invalidated. And I will also say, if you choose to decide without discussing with your insurer medical error disclosure that results in a claim, you are probably, well, I won't say probably, it is possible and highly likely with some carriers that they will invalidate your coverage. So because you disclosed the error, you didn't work with us to do it, you prompted the claim. If you hadn't done that, there would not be a claim here. We would not have to defend you. We would not be paying indemnity. So guess what? It was your choice. It's your risk, and we're out. And I've seen that happen.
I think that's really important. No, I just think it's really important, because I don't know that a lot of emergency physicians are aware of that. And I think that there's a shame factor. You get this subpoena or this notice, and you just want to kind of bury your head and just kind of see where it goes. But that's the wrong action to take.
Well, yeah, put it in the drawer and don't look at it, because it's just too upsetting. I get it. But I tell you what, I remember a case several years ago now, but it was in the state of Ohio. And I don't know if it's still this way in Ohio, but at that time, if you received a notice of intent to sue and you didn't respond by a certain time frame, it resulted in summary judgment for the plaintiff.
Oof.
Ooh.
And it happened. And it was that mindset, Jen. It was like, out of sight, out of mind. I didn't do anything wrong. I know I didn't. It'll just go away. Maybe they won't really file a lawsuit. Summary judgment, because there was absolutely no response from the defendant.
Yeah, actually, we covered some cases in the distant past where, the doctor just put it in his drawer and never responded to it, and it was a big problem. So I think everybody kind of knows that if they get that certified letter, that it needs to go to your attorney through your. They say here, in terms of the advice that they recommend, that your insurance agent is responsible for telling you about the terms of your policy. I'm not so sure that that's the case. I think you're responsible for.
How important is your coverage to you? So yeah, would you use that as a potential argument if you were going to file a claim against your carrier? Yeah, you would. Is it going to be successful? I don't know. I would rather know what my coverage is and make sure I just don't assume that somebody bought a good policy. Someone told me they bought me a tail. I want to see the tail. I want to have a copy of it, because if we do separate and go different ways, I want to make sure that I have a copy of the tail coverage when I go, what the terms are, and make sure that it's paid for. So you plan for a challenging future today when there are no obstacles in front of you, not when you're running into the problem that you're worried about.
It's like a divorce,
In a way.
Nobody plans on getting divorced, but they do, and so that's why all of these documents. That's where all of these prenups and all this other thing come to play. When in fact we didn't even think of a prenup because we love each other. Oh God. In any case, let's let's call it a day, guys. I really want to thank
Okay.
you, Jennifer, for joining us. Kevin, thank you as always. Now go see the patients
Oh, well,
that need to be seen. I hope that they're still okay.
they'll be just fine. Just want to make sure they know that their concerns have been heard, and we're happy to make their stay
Yeah,
here the care
I
that they
do know
deserve.
that
So,
you cruise the floors, looking to talk to the nurses and those kinds of things. And I think it's so important
I'm sure he does.
I think it's so important for people
I,
in the C-suite to get out onto the floors, and so many of them, after a short period of time, just kind of don't do that. And I'm
yep.
glad you're being very
Well,
atypical in
Jen,
that.
thank you, and I will take that atypical comment as a compliment,
That was a
Rick.
compliment.
And Jen knows I do enjoy people, and I love communicating with them. So being out and about and being available to them is a good thing for sure. But Jen, it's really great to reconnect with you and Rick.
Boy, it sure
Great
is.
issue as always.
Yeah, you guys are the best. It is 6 years to this month since I saw both of you, I think. So this is a
Oh
real treat for me.
God.
Happy anniversary.
God.
Right.
Well, I hope we can do it again soon.
I hope so.
Thanks so much. We'll talk with you next month. Bye for now. Thanks for listening.
Bye, everyone.